So, what are biomarkers? Biomarkers is amalgamation of the two words biological and marker. So basically, it is a characteristic that can be objectively measured and it can be evaluated as an indicator of normal biological, pathological, or pharmacological response to a therapeutic intervention. So, what is the role of the biomarker? Biomarkers enable the treating physician to tailor a personalized treatment to each patient's individual disease and need. It also helps to explain the prognosis to the patient. It also helps us to decide between the anti-VEGF and the steroids. And since OCT biomarkers are the one which provide us a live histopathological report of the retina, so it limits the number of the invasive and the costly intervention. Now the first biomarker that we are going to do is the central subfield thickness.
So sorry to interrupt, Dr. Himanshi. So very nicely mentioned. So we were starting regarding the OCT biomarkers in diabetic macular edema. Any newcomer in retina will know that any central subfield, if the central subfield thickness is increased, then we should inject anti-VEGF. So, but what happens is ETDRS has found that 32 to 66% of the patients, in spite of injecting anti-VEGF, in cases of increasing central subfield thickness, did not 6 monthly injections did not increase the visual acuity. So that's why the role of the OCT biomarkers came. So the central subfield thickness has increased. So we see the OCT and we inject monthly and we tell the patient that we need anti-VEGF injection. But the patient here, they want only the vision. No matter what you say, no matter what you explain, the patient will be concerned only about the vision. So ETDRS trial, the 40% of the patient will respond to the anti-VEGF, the treatment name, but 32 to 66%, the DRCR net protocol data is there, 32 to 66% of the patient will not respond to 6 monthly anti-VEGF injection. So that's why then we need for the OCT biomarkers. So biomarkers are small those markers in the OCT which predicts the response to the therapy. Yeah, so that's why our topic came up. That's why we put together this topic, OCT biomarkers. Yeah, go on, Dr. Himanshi. Thank you.
So the first is the central subfield thickness. In 26% of the patients, there is paradoxical visual acuity, which means that even with the increase in the central subfield thickness, the patient still having a good visual acuity of 6 by 6. So it does not represent the actual prognosis. It does an actual predictor of the final visual acuity, although it may look good statistically. So as Sir said, only 40 to 50% patient achieve significant improvement in the visual acuity after anti-VEGF treatment. In the rest 30 to 60% cases, edema still persists with reduced visual acuity even after the 6 months injection. So in 30 to 60% patient, edema persists with reduced visual acuity even after the 6 monthly injections. So when the 60% of the patient are not able to achieve the good visual acuity, are we truly justified in treating all the diabetic macular edema patients with a rigid one-size-fit-all monthly VEGF regime? So I think it's a time to move beyond the one-size-fit treatment, and we have to tailor the treatment according to the patient's need. So why central subfield thickness is not enough? Because as I told earlier, because in 26% of the patient, paradoxical visual acuity is seen. That is, in spite of having thick macula, the vision is good, 6 by 6, and in spite having a normal thickness, the vision is poor. So so instead of the central subfield thickness, the intact ellipsoid zone or the good photoreceptor integrity is more important as compared to the thickness of the retina. So the take-home message is that don't treat the OCT number, treat the patients, and we have to look beyond the CST.
So the protocol it suggests that if the vision is 6 by 6 and the central the diabetic macular edema is there, then we can observe only the metabolic parameters parameters we need to control. This was given by protocol V, that the vision if 6 by 7, 6 by 6 or 6 by 7.5 or better, then we can observe, then there is no need for anti-VEGF injection. Yeah, go. Thank you.
Now,
Two eyes with a similar CST may have different prognosis. Yes. Okay, so they may progress differently. Identical CST, but they may progress differently. Thank you.
Thank you, sir.
so the next biomarker is the intraretinal cystoid spaces. Intraretinal cystoid spaces appear as the round or ovoid hyperreflective cavities within the retinal layers. It indicates the fluid accumulation and breakdown of the blood retinal barrier. Their size, number and location correlates with the disease severity and visual prognosis. Presence of the intraretinal cyst is a hallmark feature of the diabetic macular edema activity. Larger cysts, that is more than 200 micron, and involvement of the outer nuclear layer are associated with the poor visual outcome. Whereas reduction in cyst size and number on the follow-up OCT indicate the better response to the treatment. Identifying active inflammation. Active inflammation in the retina is indicated by hyperreflective foci and fluid. So first of all, hyperreflective foci. It is seen as the hyperreflective in the retina, which represent the activated microglial cell. The absence of HRF at baseline correlate with the vastly superior visual outcome. So the presence of hyperreflective foci at the during the baseline, it indicate a bad prognosis. And second is the pearl necklace sign. It means that the pearls ring of the hyperreflective foci makes a continuous group around inside the cystoid spaces. They act as a precursor to the hard exudate, and they are a major red flag for the sudden visual loss. Then third is the subretinal fluid. Subretinal fluid appears as a dark space or hyperreflective space under the retina, and it is associated with the active inflammation. Now,
So basically, OCT biomarkers, they are divided into two categories. One is the inflammatory biomarkers, where it is driven by the inflammation, where it suggests the markers of inflammation. And second category is the biomarker indicating macular ischemia. So as Dr. Himanshi mentioned that markers for inflammation are hyperreflective foci, hard exudates, then there is the pearl necklace sign is there, and the subretinal fluid. Subretinal fluid initially was supposed to be the marker of predictive response to the anti-VEGF therapy. Now the recent studies have shown that subretinal fluid, that neurosensory detachment, has increased levels of cytokine, that is interleukin 6. So it is responds well to the steroid therapy, like a DEX implant. Yeah, thank you.
so now so now we know that if there is high burden of the hyperreflective foci and subretinal fluid, then its study indicate that 86% of the patients have achieved resolution with dexamethasone implant as compared to the anti-VEGF therapy, where only 50% of the patient achieved the response to the treatment. Now, hyperreflective foci, as we discussed earlier, they appear as the intraretinal hyperreflective dots, and there is then hyperreflective choroidal foci. When hyperreflective foci migrated from the retina into the choroid layer, and they lead to the disruption of the external limiting membrane and ellipsoid zone. Hence, the presence of the hyperreflective choroidal foci is a poor prognostic marker in terms of the visual acuity. Subretinal fluid. As we said earlier, earlier it was the predictor of the anti-VEGF response. So now we know that anti-VEGF subretinal fluid plus hyperreflective foci indicate that patient would benefit better from the steroid implant as compared to the anti-VEGF. So as the result from the RESTORE trial and the RISE and RIDE trial, the presence of subretinal fluid alone indicates a excellent prognosis for the visual outcome. Is it sir? If it is alone, sir.
Yeah. So if it is alone, then it can indicate a better response to the anti-VEGF therapy.
Yes.
But if it is associated with hyperreflective foci and your hard exudates, so then it is a marker for intravitreal steroids or a DEX implant. So in hyperreflective foci and hard exudate, the size is smaller in hyperreflective foci. So in OCT, we don't have back shadowing. In hard exudates, we have back shadowing. Yeah, thank you.
So now the bridging retinal processes. Bridging retinal processes indicate the residual neural element that connects outer and inner retina, that is molar cell and bipolar cell. So these are vertically oriented hyperreflective lines in the cystoid, and the bridging retinal processes represent the residual structural connection with cystoid and may influence the treatment response. So basically, if the bridging retinal processes are present, it means that is still some residual neural tissue is present, and there are better chances of improvement in the visual acuity. Now, disorganization of the retinal inner layer, also known as the DRIL. DRIL affecting 50 or more than 50% of the 1 mm central retinal zone was associated with the worsening of the visual acuity. So dexamethasone implant have the potential to ameliorate the DRIL. So now what is DRIL? DRIL is basically failure to identify any of the boundaries of the ganglion cell layer, inner plexiform layer, complex inner nuclear and outer plexiform layer. ELM disruption or loss of ellipsoid or ISOS junction. So when we talk about the predictor of the final visual acuity, if the baseline ELM integrity is good, then it is a good predictor. It is a good predictor of the final visual acuity after resolution of the diabetic macular edema. It is graded into three classes. Grade 0 when there is no disruption of the ELM and ellipsoid zone. Grade 1 when there is ELM disruption but ellipsoid zone is intact. Grade 2 when both ELM and ellipsoid zone is disrupted. Third biomarker is the parallelism. It is a rather new biomarker in which the subfoveal area covering the photoreceptor layer are skeletonized and the orientation of the segmental lines was termed as parallelism. Photoreceptor layer status at the fovea include the continuity of the ELM inner segment ellipsoid line was studied in this. HRF migration and microglial activation. So hyperreflective foci, how to differentiate between the hyperreflective foci and hard exudate? First of all, on the basis of size. Hyperreflective foci are small dots, less than 30 micron in size, whereas the hard exudates are larger in size, that is more than 30 micron. And second difference is that there is no back shadowing is present in case of the hyperreflective foci, whereas back shadowing is present in case of the hard exudates.
So one important point to remember in the cases of increasing diabetic retinopathy severity, so hyperreflective foci will migrate from inner to the outer retina if cases of increasing diabetic retinopathy severity. So we see like in the from the inner retinal layers you have the choroidal foci. When there is a choroidal foci, that means it has migrated from the inner retinal to the choroidal layers, so that the severity of the retinopathy has increased. So that is one of the important biomarker, the hyperreflective foci, the migration of the hyperreflective foci. Yes, thank you.
The next biomarker is the giant cyst at the fovea. Large ONL cysts, which are of the size more than 200 micron, have a negative impact on the macular function, and it predicts the worst visual acuity outcome even after the anti-VEGF treatment. Size of the cyst is correlated with the extent of the macular ischemia, and both horizontal and vertical increase of the cyst increase with the severity of macular ischemia. The another point to be noted is that the prediction of the visual acuity also depends upon the fact that how much of the neural tissue is remaining between in the cyst. If there is very little or no neural tissue is remaining in the cyst, so then it indicates a poor prognosis.
So there is another classification in the giant outer nuclear cyst also. So giant ONL cyst, what it does is, it basically, as you can see in the image, it compresses on your photoreceptor layer. When it compresses on the photoreceptor layer, the conduction hampers. So when the cyst, there are three classifications. The size they have mentioned in the literature as less than 100 micron. The small cyst, the intermediate cyst as 100 to 200 micron, and the largest cyst as more than 200 micron. So when it compresses the photoreceptor layer, there is the conduction is not hampered, so your visual prognosis is decreased. And the bridging retinal processes plus the cyst is very important. If the bridging retinal processes is there, it means the remnants of the Muller cells are there, the conduction is there. And third thing is the residual tissue, as Dr. Himanshi mentioned, residual tissue between the cyst and the inner retinal layers. So these three things are very important. Yeah. Thank you.
Now, the therapeutic diverging matrix. Inflammatory markers are functionally sign of the chronicity. So, standard anti-VEGF treatment is preferred when there is edema in the inner retinal layer only, when the patient is presenting with the baseline presentation, and if there is any traction or membrane is present, then the surgical or vitrectomy is preferred. In corticosteroid or dexamethasone implant is preferred when there is present of the hyperreflective foci, if there is high baselines increase in the CST, hard exudate or pearl necklace sign is present, subretinal fluid is present, and there is severe DRIL presentation. These are the conditions when we prefer corticosteroid over the anti-VEGF. Now, what are the OCT biomarker which predict the steroid response? When there is rapid reoccurrence post anti-VEGF or steroid treatment is noticed in when there is hyperreflective dots, foveal eversion, which is a sign of persistent traction, intraretinal hyperreflective material, and the disruption of the ellipsoid zone. Poor visual outcome despite good anatomical response is seen in the DRIL, ELM, ellipsoid zone disruption, and the exudate or cholesterol presented fovea. Now, what are the conditions in which the better response is seen to the steroid? One, if at the beginning of the disease hyperreflective dots are present, high central macular thickness, hard exudates, and DRIL. These indicate the response that the response will be better with the steroids as compared with the anti-VEGF. Now, the combined presence of the hyperreflective foci, pearl necklace sign, DRIL, and progressive hard exudate indicates a highly chronic and inflammatory environment. So, in this chronic state, anti-VEGF resistance is usually there. So the drugs with a higher drying effect, especially with the dexamethasone implant, are highly preferred to target the inflammatory cascade. So all of these inflammatory states like hyperreflective foci, DRIL, pearl necklace, hard exudate, we have to shift to the dexamethasone implant as compared to the standard anti-VEGF therapy. Now the prognostic spectrum matrix. Isolated markers must be synthesized to predict the final visual acuity and manage patient expectation. Positive outcome is indicated if there is intact external limiting membrane, if there are bridging processes are present which indicate the neural tissue, if there are strict outer retinal parallelism is present, if the choroid is thick, and if there is decrease in the central subfield thickness. Whereas the poor functional outcome is indicated by disruption in the inner retinal layer, if there is a disruption in the external limiting membrane, if the subfoveal hard exudate which are present subfoveally, and if there is the choroidal hyperreflective foci, plus there is cyst of the size more than 200 micron with remaining tissue. So the clinical decision matrix, when to give anti-VEGF, when to shift to the dexamethasone implant, and when to do the surgical intervention. So if the subretinal fluid is present, if there is inner retinal edema without any massive cyst, and patient have intact external limiting membrane, ellipsoid zone, there is minimum HRF, then we should proceed with the monthly anti-VEGF injections. But if there is high baseline CST, hyperreflective foci is present, DRIL is present, hard exudate present at the subfoveal location, pearl necklace sign is present, then we should switch to the dexamethasone implant to target the chronicity. And surgical intervention. Surgical intervention is required when there is a visible tractional element and there is a taut posterior hyaloid membrane. So, vitrectomy is done to relieve the mechanical tension. In this case, medical therapy alone will not be sufficient. So, the dynamic nature of the diabetic macular edema, we have to, as we said before, we have to look beyond the central subfield thickness. It may indicate the volumetric response, but structural but it is not the predictor of the good visual acuity. So whenever we are assessing a patient of the diabetic macular edema, we have to evaluate OCTs from the top to bottom. We have to evaluate every OCT specially from the traction to the of the vitreomacular interface down to vascular health of the choroid. So, individualized therapy. Biomarkers do not always work in perfect tandem, so we have to use them comprehensively to manage the patient expectation and to change the treatment between anti-VEGF, steroids and the surgery. Now, as the OCT biomarker of the diabetic macular edema. So, master tailored treatment flowchart. This is the diabetic macular edema is not a static disease which can be treated with a single drug. It's a dynamic multifactorial condition which require personalized pathway routing. So first of all, obtain the baseline scan and measure the central subfield thickness. Then we have to go through whether there is inflammatory signs are present or the structural signs are present. Inflammatory signs are hyperreflective foci, pearl necklace, and structural signs include the DRIL, parallelism. So then we have to set the patient expectations based on these markers. Whether we have to start the standard anti-VEGF procedure or we have to target the corticosteroid implants. So conclusion is that every patient need a personalized treatment rather than one treatment fit all kind of thing.
So very nicely mentioned. So in a nutshell, so never treat the printout alone. Never treat the printout like if we have a printout in our OPD, so in the central subfield thickness of this. So never take always go to the OCT machine and or on your computer, scroll the whole OCT. What I mean to say is scroll the whole OCT and then individualize, personalize the treatment on patient to patient basis, because we are mentioning that OCT biomarkers such as hyperreflective foci, neurosensory detachment, these are inflammatory biomarkers are there. So we should switch to steroids. But in all, we should see the patient as a whole. Like what is the status of the patient, like I mean to say whether he or she is a steroid responder or not. So we should, if it is a treatment naive patient, if he or she is a young patient, so the side effects of the steroid, cataract versus glaucoma, we should keep in mind that also. And also the metabolic parameters does his metabolic parameters permit the kidney status, the sugar status, or the neurological and the cardiac status. So all we have to treat the patient as a mind. So that's why the tailor-based approach, and never treat the OCT alone, because we have in our OPD we have seen in cases like one case I remember we injected ranibizumab to aflibercept injection to ranibizumab injection. It was a case of vein occlusion, but the vision was 6/18 only. It did not improve much. So the vision did not improve much. So when we injected steroids, then we we looked at the OCT very carefully and very deeply, and then we found the inflammatory biomarkers such as the hyperreflective foci and the hard exudates, and even the DRIL we found out. So then we gave them an option of DEX implant or an intravitreal triamcinolone. So with that, now the patient is doing a little better. So this tailor-based approach is very important. Treatment naive patient, my first line of therapy is 2 doses of anti-VEGF. If it is not 2 monthly doses of anti-VEGF, loading doses. If it is not responding, then you can switch to the steroid, the DEX implant or the intravitreal triamcinolone. Now we have our senior ophthalmologist Dr. S.K. Gupta sir with us. Even before OCT came into, OCT जब इन्वेंट भी नहीं हुआ था सर, तब से डायबिटिक मैकुलर एडिमा देख रहे हैं सर. हम तो ब्लेस्ड हैं कि OCT है, तो हमारे पास पता है कि एडिमा इतना है. एंड ये सब बायोमार्कर्स हमारे पास OCT की वजह से। तो पहले तो क्लिनिकल जो फाइंडिंग था, क्लिनिकल जजमेंट इतना स्ट्रॉन्ग होता था कि सर के ज़माने में, तो सर से पूछना चाहूँगा सर कि जब आपके पास डायबिटिक मैकुलर एडिमा या डायबिटिक रेटिनोपैथी वाले पेशेंट आते थे तो हमको बताइए सर, क्लिनिकली आप क्या देखते थे? हमको मैक्यूला में कुछ ऐसा लगता है तो हम OCT की मदद ले लेते हैं। जी सर।
गुड मॉर्निंग टू ऑल फेलोज। उस टाइम का डायबिटीज़ इतना कॉमन नहीं था जितना आज है। पेशेंट्स काफ़ी कम आते थे, लेकिन फिर अब फंटस के लिए तो बहुत ही कम आते थे। उसमें जो मेन क्राइटेरिया में देखने का होता था, उसमें बेसिक नॉलेज बहुत ज़रूरी है। एक तो जो वेस्कुलर वेनस डायलेटेशन, फर्स्ट एंड फॉरमोस्ट माई साइन वाज वेनस डायलेटेशन, सेकेंड हार्ड एक्यूरेट, एंड थर्ड दिस हेमरेज, डॉट हेमरेज एंड एन्यूरिज्म। इससे हम पूरा डायग्नोसिस करते थे। इसके बेसिस पर हमारा ट्रीटमेंट तो कुछ था नहीं, पहले सिर्फ लेजर अवेलेबल थी, उसके लिए भी हमें बाहर भेजना पड़ता था। इसलिए हम ज़्यादा वेल इक्विप्ड थे, लेकिन फिर भी अब डायग्नोस तो कर लेते थे, लेकिन पेशेंट रेफर ही होता था ज़्यादातर। तो थैंक यू डॉक्टर निपुण एंड डॉक्टर हिमांशी फॉर एक्सेलेंट प्रेजेंटेशन। डायबिटिक मैकुलर एडिमा इज द मेन काज ऑफ ब्लाइंडनेस इन डायबिटिक रेटिनोपैथी। अर्ली डायग्नोसिस इज वेरी एसेंशियल। थैंक यू।
So please have a seat. We have some questions also. बैठे तो जैसे कि सर ने बोला कि पहले के क्लिनिकल जजमेंट, क्लिनिकल वो बहुत इंपॉर्टेंट होता था। अभी भी क्लिनिकल जजमेंट, जैसे सर ने बोला कि पहले जब एंटी VEGF नहीं थे, बिफोर द एडवेंट ऑफ एंटी VEGF द लेजर्स हैड अ रोल। नाउ ऑल्सो फोकल लेजर्स हैव अ रोल। सो फोकल लेजर्स हैव अ रोल इन केसेस ऑफ नॉन सेंटर इन्वॉल्विंग डायबिटिक मैकुलर एडिमा। सपोज वी हैव अ OCT with a non-center involving diabetic macular edema, center is okay, and when we see the clinical fundus picture, though temporal to the macula, there is a circinate retinopathy with a microaneurysm inside. So that microaneurysm is leaking to cause the diabetic macular edema. So we do a focal laser and blanch the microaneurysm. The location of the microaneurysm should be more than 500 micron from the fovea. So how do we do the focal laser practically? So what we do is we focal laser is the grade 1 burn we use. That is the just visible burn. We go to the periphery of the retina, titrate the burn, like it should not be grade 2 the grade 3 burn. So depending on the power, we titrate the burn. It can come at around 40-50 milliwatt or even at 100 milliwatt, depending on the machines also. Then we blanch the microaneurysm in the circinate retinopathy. So focal laser still has a role in cases of diabetic macular edema. So now these are the 5 principles. Yeah, go on, Dr. Himanshi. Thank you.
So now 5 principles to carry into every clinic. Central subfield thickness is necessary, but it is not sufficient alone. We have to always investigate the tissue quality. Now, DRIL and ellipsoid zone integrity are the 2 of the strongest structural predictor of the final visual acuity. Dense hyperreflective foci plus subretinal fluid often signals an inflammatory phenotype that may respond better to steroids. And then we have to reassess phenotype after loading. Do not continue a failing strategy indefinitely. So if the patient is not improving, we have to change the treatment approach. We have to counsel the patient with structural damage honestly, that patient should be properly counseled and the expectation should be realistic.
So we have fellows with us. So I want Dr. Pallavi, are you there? Dr. Pallavi would be joining us in the month of September and October. So there is I just jot down 2 important questions, 2 important like a quiz questions, so that we can understand this topic better. So we had a 58-year-old teacher from rural Rajasthan. So this was the OCT picture. Large central cystoid spaces involving the fovea intact, the outer retinal bands, and mild subretinal fluid was there. His vision was 20/80 on the ETDRS chart, and the scattered hyperreflective foci, and there was no definite DRIL, and the central subfield thickness was 458 micron meter. With single biomarker most strongly reassures you about the visual potential in this eye. This is the intact outer retinal bands and the absence of DRIL. Okay. So what is the most likely visual prognosis? Favorable, because there were no DRIL and outer retinal bands intact. The second case, 64-year-old farmer has a recurrent diabetic macular edema and vision was 20/100. Therefore, 4 prior anti-VEGF injection. This is the OCT picture. There was a DRIL in this, disrupted EZ zone in this, thin outer nuclear layer is there. So does improved CST guarantee visual recovery when DRIL and EZ disruption persists? So I want to ask Dr. Himanshi, like what would be the treatment of choice in this patient, and what regarding the prognosis?
So the next step should be that we have already given the 4 injection of the anti-VEGF. So we should switch to the steroid implant earlier.
So as Dr. Himanshi mentioned, because of the recurrent, we have given already 4 anti-VEGF. DRIL is also present. There's a disruption of the. So the DEX implant has the potentiality to ameliorate DRIL. So we should switch to the steroid implant early. So A option is ruled out. C option is ruled out. Because C option we can observe when there is a persistent diabetic macular edema. There is an entity called as persistent diabetic or a recalcitrant diabetic macular edema. In spite of many injections, anti-VEGF and many steroid injection, the vision is around about the vision is constant. It is not improving. Then we have only one option for the strict metabolic parameter control and to just observe on topical NSAIDs drops. So as Dr. Himanshi mentioned, consider early steroid implant because of the DRIL and the recurrent diabetic macular edema. So this is the nutshell. Measure CST, phenotype the eye, choose the first line of agent, reassess at 3 to 4 months, and personalize the long term, because we are looking at the long term visual gain. Always counsel the patient. So see, diabetic is a lifelong disease, so always counsel the patient the treatment will go on for long, and it depends on your duration of diabetes and the control of the metabolic parameters. Not only the diabetes, not only the blood sugar, the lipid profile, and even the renal parameters. So thank you for your attention. Thanks a lot, Dr. Himanshi. Any questions to Dr. Himanshi are most welcome. Yes, sir.
There are 2 factors essential for diabetic retinopathy or macular. One is ischemia, second is anti-inflammation. Inflammation, there are new theories, age and age theory, whatever. So we have to take anti-inflammatory drugs also, which are in developmental stage. What are they? With anti-VEGF, we have to use anti-inflammatory drug also. Steroids है, अब नए भी डेवलपमेंट हो रहा है, oral drugs भी आ रही है. There are advanced glycation end products, and there are receptors in retina for advanced glycation products. There are reactions, then you liberate the chemicals, C proteins and other interleukins, which causes retina barrier breakup, the retina barrier breakup. So they cause infection. For them, they are developing drugs, anti-inflammatory drugs. नाम तो मेरे को भी याद नहीं, लेकिन अभी आपका आईजो पढ़ना उसमें है अभी. थैंक यू.
बहुत अच्छा point, very nice point mentioned by there's a education end product. So newer drug therapies are coming up, advanced glycation end products to ameliorate the diabetic retinopathy. Sir, one point I remember, इससे मेरे को एक चीज़ याद आई sir, that lipid lowering that is the phenofibrate they used to prescribe in patients of hard exudate plaques, phenofibrate drugs they used to prescribe. Any more questions or any opinions, Dr. Lalita? Any questions? Yeah. So thanks a lot. Sir, it was a very sir. Any questions? So thanks a lot. It was a very nice session on OCT biomarkers in diabetic macular edema. So it was a very nice question. Any questions you have? Please, I'll put this on YouTube also. You can ask the questions on YouTube or mail to me at nipun.bagricha@gmail.com. Thank you, Dr. Himanshi.